tag, bone sharpening was done. At the same time, we started dissection in recipient. It was shifted to OT 3:30, 7:30 a.m. So two team approach. So we elevated the flaps and we identified all structures. Uh, Bone fixation was done with plate and screw and artery vein. We did actually two arteries, three veins, both sides using 10-0 nylon, and muscles were weaved with 2-0 vicryl. This is after perfusion. So after one artery, one vein, we are able to see good perfusion. It's at 2 o'clock in the afternoon. Yeah, obviously, it's a teamwork. You can see this side, anesthesiology team is working this side, and surgical team, they are doing their job perfectly. This is at the end of surgery. All wounds were closed primarily. It is at 8:30 in the evening. All wounds were closed primarily. Both limbs appear viable. So it's at 9 o'clock. You see the elected team. All surgeons are standing there, and patient is still in ventilator. This is the flow chart. It gives that all events. You can see main points. Patient in time is 7 a.m. and patient out time is 8:15 p.m. Almost 12 hours. And most important thing is ischemia time. We are able to reperfuse the limb within 6 hours, both right and left, within 6 hours. And all other points by like bone fixation time, arterial anastomosis time, vein anastomosis time. So within 6 hours, we are able to reperfuse the both limbs. That is the advantage. So involving other departments also very, very important. Our nephrology department, because they are doing renal transplant routinely for the past 10 to 15 years. So they are well versed with all immunosuppressant drugs. So all immunosuppressant drug part, it is taken care of by our nephrology department. And other department like anesthesia department, blood bank, pathology, biochemistry, microbiology, immunology, all these things very, very important. Everybody has their own role. Most important is administrative department. Our dean is kind enough to give all things, whatever we asked, we supplied immediately, because the government setup, we getting things are little difficult, but our dean is very supportive, and we arranged all things for hand transfer to go with good outcome. The next day, 8th was it went to media, and whole Chennai, they were asking, Stanley Hospital done double and transfer, how is the hand, how is the hand, lot of information, lot of social media advertisement, it's going on. It went viral. So post-operatively, second day, it developed little hemodynamic instability like PP fall and electrical imbalance, which are treated with our anesthesia team nicely. And our team, we were monitoring the patient every 2 hours. We check the viability of the fingers, how is the, capillary filling, all clinical examination, watching for signs of any rejection and watching for any signs of any infection. So this is the regimen we used. It's all advised by our nephrology team. So induction by Bacillus and tacrolimus, MMF, and methylprednisolone. These are three immunosuppressant drugs we used. Antibiotics, teicoplanin and meropenem. Antifungal, fluconazole. These all dosage, everything is monitored by our nephrology team. So we don't have any specific transplant ICU. So what we have done, we changed our OT into ICU. So we kept the patient in the OT itself for 2 weeks. So we monitor the patient, everybody will change the dress and will go inside, and we monitor. So our postgraduates are doing around the clock duty for 2 weeks, like that. So he was there in OT for 2 weeks. This day two, there's a small problem with the swelling of the forearm and fingers. So we were worried, and we don't want to take any risks. So we did fasciotomy, and same time we did skin grafting also. It's day two, and the patient was expiated on day two. We have done routine biopsy and cultures. Day three, the biopsy report came as grade 1 rejection, early rejection, they told. So we started methylprednisolone again. and there was a little bit blubs over the right hand, which was treated with clobetasol application, and the patient is recovered from that. And day three, we started oral fluids, patient food started, and visitors are allowed with all sterile precautions. And take was little high, which was monitored by our nephrology team. And this is the fifth day. Father beats son. Both are very happy, and you can see the smile in the father's face. So this type of splints, above elbow splints, we use for after 1 week. So day fifth day, we was mobilized with the above elbow splint. Our postgraduates were mobilizing the patient. So from third day to seventh day, so at the end of 1 week, and patient was feeding was given by his sister, own sister, inside the theater. And what he was happy, and he told he was little boring. So what we have done, we have arranged a TV and we put lot of movies. You can see the picture. He was watching the Sivakarthikeyan movie inside the theater. So physiotherapy started after 1 week, and chest physiotherapy, hand mobilization was started. And after 2 weeks, we shifted the patient from ICU to ward. So visitors were restricted. So what we have arranged a teleconference like mic, and we can talk with the visitors outside waiting. So we don't want to take any risk because in the first case. So this is picture after 2 months. You can see the acceptance. The color match is very good for this guy, and the bulk of the forearm also, it's almost same for his stature. So it is almost equally both right and left limbs. It's going very well with his body stature. He was doing physiotherapy regularly. So started initiation of movements. So it is at the end of 3 months. He is able to feed himself with spoon, and physiotherapy is still going on. So how do we move? So the patient has to be in immunosuppression for lifelong. We have to watch for opportunity infection. The more transplant, because since we are in government setup, lot of inquiries came, and more patients are asking for transplant. So it's going to be a new domain of microsurgery. We opened a transplant clinic, and already we have 80 patients waiting for hand transplant. Among them, 20 were bilateral hand amputees. So this finally, it's almost 6 months over. So this is a picture you can see. 3 months, this wrist and elbow is okay. Fingers, long flexors is acting, but intrinsic is not at come. It's 6 months post-op. Patient is very happy. This is at the end of 1 year. You can see how he is playing a small ball. He is able to do routine activities with long flexors, but the intrinsics not yet recovered. This is a 1 year post-op. This is 1.5 years. He is able to take food himself. He's eating himself. So this is a news. After 1.5 years, he got married. So he called us for his marriage, and me and Ramadev madam, and Dr. Sumati, we went there, and we gave our blessings. That bride is very is having a friendship with him, so she's accepting him. So we went for his marriage, and we blessed him. So 3 months back, he had a child also. Now he's living with healthy, joyful family. This is the team which led by Dr. Ramadevi and me. You can see Dr. Sumati is Dr. Mahendran, anesthetist, all our postgraduates. So we got appreciation from Tamil Nadu government for this hand transplant. Thank you very much for your help. Yes.
Next, we have Dr. Dinesh Kumar.
Even if just put, please bear with me. So our current status, as Dr. Mohit has already observed, we have done 3 bilateral transplants till date. First was done in August 2017. Second was done in October 2018. The third transplant was done in March 2019. First two recipients are doing well. They're on follow-up. The procedure followed by for the transplants are more or less the same as followed in Amrita and Stanley, and Dr. Jayakumar has just already given a very good presentation about that. I guess two things I might add to this were that we regularly provide prosthesis for donors. I don't know if Dr. Kumar touched on that. We provide prosthesis for the donors so that the disfigurement is not too evident. And the thing was that the second patient, we had to transport the donor hands from Bangalore to Pondicherry. It was done by road. It took almost 6 hours for the transport out. That patient had, the second patient had one transplant just below elbow level and one at upper arm level. Both the first recipients are doing well on they are on regular follow-up in their attack levels. Luckily, the first transplant patient had any rejection still date.
Sorry, Dinesh, sorry to interrupt you.
Yes.
We are not like there is a big lag in your voice and not able to hear anything clearly. Is your net all right?
I'm at home. I'm at home, so I don't know. This connection may not have a good option.
Okay, yeah.
I can try video. That may improve the screen sharing at least. Is this slightly better?
Yeah, it's slightly better. Yeah. You can come near the mic also because your voice is not at all clear. We are not able to hear you.
Okay, I'll try to be a little more louder.
Yeah. This is better. You just come near the mic and you may switch off the video. If your video, probably if that improves, we'll be able to hear you.
Yeah, I've already done the.
Yeah. Thank you, Dinesh. Carry on.
So, like I was saying, the first two transplant patients are doing well, and on follow-up, the same problem as what Dr. Jayakumar has noted, the intrinsics haven't recovered, and so the patients have just about control over the wrist and some amount of control over the flexion of the fingers. The second patient, his left hand, which was done at around the upper arm, he has just recovered his elbow flexion, nothing else. So, and we had already informed him about the poor recovery on the left arm. Okay with that, right? The third patient unfortunately expired on the post-surgery due to hemodynamic failure. What we have come to the conclusion of. Like I said, the procedures have as the same as what is done in Amrita and in Stanley. We haven't done any further transplants primarily due to lack of donors. Although we have only one recipient on our waiting list as of now, and that to a unilateral recipient. And that's it. questions regarding or doubts regarding our procedures we follow or reason for the bad outcome in the third can be brought up and try to answer. So yeah, thank you. That's my presentation.
Dinesh,
Yeah.
Dr. Selva. So, what was the two things I want to ask? What was the ischemic time for the third one, which had a problem, and suspect mainly the ischemia time or any acute rejection sort of thing? What is the main reason for the failure in that case?
Can I just ask before that whether my screen share has been out? Has my screen share been shown?
Yeah, we are. Hello, Dinesh. We are able to see you,
Yeah.
but not hear you well. But we are able to see you.
Okay, the mic is on, so I don't know what the problem is. I'll try to answer Selva's question. If my audio is still not good, probably I can come back later.
You can tell now.
There was no evidence of rejection reaction. The skin biopsy samples, there was no rejection reaction. The only thing that we noted was that the patient had an elevated pulse rate prior to the surgery, and
Sorry, Dinesh. Dinesh.
yeah,
We are unable to gain much out of your presentation because our organizers are suggesting could you use
headphone
headphone with a
with
speaker.
a mic.
Yeah,
With a
that
mic.
would be because you have three slides, but if you can hear what you are saying, then only we can respond.
Correct.
If you have any headphone,
Yeah, I'll try that.
just try. We have time. Then we can listen to. You can respond to Selva's question.
Yeah. So I think you can proceed with other presentations. I will get back once I get my headphones.
Or Dinesh.
Yes, sir.
Dinesh, what we will do, you arrange for your headphone, and meanwhile, I would invite Dr. Iyer to talk, and after his talk, you can answer Selva's question.
Yes, sir. Sure.
Okay, that will give you time of 20 minutes to arrange for a headphone. Okay.
I've got that.
And if you have got your headphone, then you can just come back, and then you come back and answer your questions. Yeah. Now we are not hearing you at all. We can't hear you, Dinesh.
Sir, I think it is better that you proceed with other people's presentations.
Yeah, yeah, Dinesh,
Yeah.
speak, speak,
Yep.
please.
I
Yeah.
think you should proceed with others.
No, no, no. Now we can hear you. Now you can answer.
Oh, okay. So to answer
Sorry, Dinesh. What
Selva's
I
question, yes, sir.
sorry, Dinesh. Actually, we could not hear anything of your presentation, and now we are hearing. So if you can summarize it in 5 more minutes, we'll be able to hear. We could not hear anything.
Sure, sir. Sure, sir. Uh,
You can show the slides
okay.
again, please. We have only 3 slides. You can show. That'll be great.
Okay. Okay, I'll do that.
The first time we are able to hear you.
Yes, sir. Just hold on. Okay, my browser is preventing share screen. Yes, sir. Is it now visible?
Yeah, yeah.
Okay, so I'll just run through the slides again.
Yeah.
Like I said, we have done 3 bilateral transplants till date. The first one was done in August 2017. Second one was done in October 2018. And the third one was done in March 2019. The first 2 recipients are doing well. They're on regular follow-up. Uh, both these patients have fairly good elbow and wrist functions, but like Dr. Jayakumar had noted, their intrinsic functions are not good. The third patient expired on post-op day 3, primarily due to hemodynamic failure. For all these 3 patients, the procedure was almost the same as in Amrita and Stanley Hospital. No further transplants have been done, primarily due to the lack of donors. And currently only 1 recipient is on waiting list. We regularly provide... Hello?
Hear you.
Well, they're able to hear you, Dinesh. Please continue.
Yeah. So we regularly provide the prosthesis for the donors so that we reduce the disfigurement of the donor. For the second patient, we had to transport the organs from Bangalore to Jipmer by road, which took about 6 hours. Other than that, we are not really doing anything different. So, like I said earlier, you can pose certain questions and I will try to answer. To answer Selva's question earlier, we didn't find any rejection reactions. We did check for them both by blood tests and by skin biopsies. The only thing that was of significance was that we saw a high pulse rate on the in the patient pre-op. On checking the literature, we came across the reports that such patients, especially quadrilateral amputees, have constricted blood volume. which may have contributed to the hemodynamic instability post-op for this patient. So, Selva, if that answers your question.
Yeah, yes, yes, yes.
Dinesh, could
Yeah.
you just show your third slide, please? And
Yes, sir.
this and what is what are the levels of your first was proximal forearm? Other two were
The first one was upper forearm level. It's a
okay.
BK amputee.
Uh-huh.
The first, in the first patient, the right arm was at around 10 centimeters below elbow. The left arm was 7 centimeters below elbow. For the second patient, both his the right side was yeah 10 centimeters below the elbow, and the left arm was above elbow amputation at just below deltoid level. For the third patient, both his amputations were below elbow, but the uh, the lengths were less than 7 centimeters. So we couldn't really do the way you do it. We had to do the bone fixation at the humerus level. The rest
Okay.
of the muscles were as per
Okay.
the other
Okay.
procedures.
So can you hear me, Dinesh?
Yeah,
My
crystal
question
clear.
is, what is the functional status? Like you are saying that the intrinsic function has not come in the first two,
Yeah.
but what actually they are able to do now with their life?
Um, the
How
first patient
functional?
is fairly independent. First patient is fairly independent. He is driving a vehicle. He's able to ride a bicycle. He's able to feed himself, clothe himself. And the last time he came alone for follow-up, that was the first time he has come alone for a follow-up.
Okay.
And the second patient, um, he had lost a lot of body weight due to CMV infections, and his right arm function is just about adequate to help him in his daily work, but the left arm is almost completely useless.
Left side.
Yes,
So
he's got about elbow flexion,
okay.
nothing else.
So he gets elbow flexion because the second one is at, you said that at the level of humerus or at the level of proximal forearm.
Second one, left arm is upper arm,
Is upper arm at
below
the level of what you said deltoid.
deltoid insertion. Yes.
So he is able to do only elbow flexion.
Yeah.
Okay, but other functions have not come over the period of last 2 years.
No. Yeah, he's got sensations,
Okay, 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 okay.
but no motor functions.
So what do you like?
Not even wrist stabilization.
Okay, so what do you plan for him? Like,
I'm really lost there. We thought we'll do a nerve conduction and EMG studies first,
uh-huh.
because his extension of the elbow is also not really powerful. So we thought we'll work him up almost like a brachial plexus patient.
Okay. So just one more for my understanding. When you did
Mhm.
the transplantation, you used the biceps from the donor, or the biceps and all the triceps muscles were from the donor which you innervated by joining the nerves, or you
Yeah,
use
we no the donor muscles because the patient had nothing below the deltoid. the biceps stub, it was basically a stub of muscle
Okay, okay. So you
and fibrosed, so no use.
you tried to reinnervate the donor
The
muscles.
biceps and the triceps, yes.
Okay, okay, okay. Fine. Thank you, Dinesh. Selva, any other
Yes, sir.
questions?
Thank you.
I think
Dr. Jimmy? Yeah, that, okay, fine. Thank you. Thank you,
Yes.
Dinesh. So now
Yes,
I
sir.
would invite our Professor Subramaniam Iyer from Amrita Institute of Medical Sciences to share our experience of attempted 9 double hand transplants at Amrita Institute of Medical Sciences since 2015 January. So welcome, sir. Please enlighten us.
Is it connected? Thank you very much, Mohit, and welcome you all. Because this is, I would say, at the outset itself that this meeting has been slightly off. I'm audible, no, Shelva?
yes, sir, very much, sir.
Okay. So I just was saying as a preamble that this meeting has been of a bit of, um, in a way, slightly you can call it disorganized or disorganizedly organized because of the issues, because we are thinking of having a beautiful meeting here in Kochi, because the venue is fantastic, and then we all missed that we couldn't do it properly. But we again had, what is this? Okay. So what we had was to have an idea about the whole experience across the country. This would be a forum for looking at it. And I think we should make it a point every year. Before I go to the talk proper, I would like to mention that we should have a forum where we are discussing these issues, because it's a very close forum, and then all of us are new to the field, and then we want to take it forward. Then only a frank discussion among us will take us forward, and that is why this is very, very important that we all present. In fact, Nilesh and Vinita could not be here because of, this was again a slightly, hastily arranged sessions. So that is the reason. But it would have been very good if we had them also here, so we could all learn from each other's issues and then take it forward. So I think next year onwards we should make it a point that we definitely report all our outcomes also in a way like this, in a session like this, spending 2-3 hours. So let me go into our cases now. We have, as Mohit said, 9 cases. The first one was distal forearm, then distal forearm, then proximal forearm, supracondylar, proximal forearm, and one was upper arm, and then middle arm, again 2 proximal forearms. So our proximal forearm shares are much more than all the other cases. Now, I have to take sort of bail out of the spelling mistakes, because it's not my slide. My dear fellow Vasundhara prepared it, so I will take responsibility as a faculty member. So don't worry about it. Now, the results: time transplant 6 years 10 months, and the other one is last one is POD 14. I will just go through each. We learned a lot from all these cases, so I will tell you briefly what we learned and what we have to we all can understand from our cases. Manu was the first case. I would call him one of the most successful of our cases. In fact, the first one being doing it in a distal forearm for this guy who is highly motivated has made a lot of difference to our transplant program, in fact, because of his successful sort of outcome. You would say 95% successful outcome, and his success in life is still keeping us motivating to do transplants. He is working with us as a transplant manager. I mean, he counsels everybody. So he is the real motivator for our team also. Seeing him doing so well, in spite of the mishaps and issues which followed in our following cases, which I'll come to, he is one guy who keeps us thinking that transplants are one of the best alternatives for this type of patients. He is doing extremely well. He has got 2 children. He married his physiotherapy nurse. He is working with us, and he is one of the guys who equate with all our hand recipients, potential hand recipients as well as transplant people so well, because he has undergone these things, and so we leave it to him to discuss with all the patients and the families the issues related to it, and then it makes a tremendous sort of difference in their attitude. The problem with him was a mishap. I will come to that, what are the problems, but this was one. We had an acute skin flap necrosis within 12 hours, but even though it was a first case and we were all a bit perplexed to what to do, and we made a slightly, I would say, bold decision of going in immediately, taking an ALT flap and putting it, debriding the whole area and putting it together. Otherwise, I don't think he might have succumbed, because of the way we have seen in other patients, tissue infection and necrosis and infection can be fatal even. So I think that first case was when we decided to do this debridement and flap transfer. That was one of the major decisions which we made, and we executed it so well without causing much problem. So which looking back might have been one reason why we are still having him as a beacon of sort of transplant, hand transplants in the country even. Longest follow-up 6 years, 10 months. The second one, Abdul, was again distal forearm, very motivated guy. He again had around 90%, Mohit, 90%, we will call it as even intrinsics and everything working. 90, all intrinsics. So both these patients, distal forearms, recovered all the intrinsics, and this fellow went back and started working in the army, and then he was doing very well, in fact, and then this was this. Does it work? It works, no? Oh no. He went back and joined the army, and then 5 years later, after the whole thing, he succumbed to a terrorist attack which he was worried about, and then only problem he was having was persistent gastric issues which was there. He went back to Afghanistan. He said he didn't lactose intolerance and all those things. Tried a lot of things, and then our Dr. George and team thought that might be MMF related, so reduced the dose, changed this thing and all those things. Finally, what happened was that somebody took him and then gave what you call the herbal medication, Otamoli type of thing from the Afghan some hills, and he said that after having that everything stopped, so which we are not sure. But he had a very troublesome stomach and colon issues for about 1.5 years, and we were all worried because it could be related to colitis and all those things. So finally he did well, and he died, but again he was a very good patient and good ambassador for the whole hand transplant across the world. But anyway, we are all sad, but he died in his own way. He would have liked to as a soldier. So let us be. This was our first forearm transplant. Again, done 5 years back. Jit was doing extremely well. I would say he was doing very well. He did. This is the video which Mohit has shown in the presentations. He was doing extremely well. He also, see, you can see the hand function, intrinsics coming back, and then how much percentage, Mohit? Jit? Mild clawing only at that distal forearm level. So you can see this thing. See, now his problem was he was so good. When I think this video was Mohit took to sort of counter argue against the prosthetics with Hari Venkatramani, and then Mohit's video of he showing swimming was the thing that would have clinched the whole argument, that he could continue his life so well, in that way, where a prosthetic hand could have never ever matched that. See, the problem was that was about 1.5 years later after the transplant. Unfortunately, what happened was that he had a lot of issues. He was from a poor background. We had to help a lot. We had to crowdfund for his even surgery. Then finally what happened was that his father got sick. He had some stomach cancer and all those. He was from that tribal area of Kerala. So we lost contact of him, and then his in the sort of thing of treating his father, and there was some sort of misguided advice by local so-called local untrained people. So he stopped the immunosuppressants for some time, and then it started the whole process of rejection, and then the histopathology was bit confusing, but finally we came to the conclusion that it's a chronic rejection process which is continuing, but is back on immunosuppressant and retaining his hands is functional. But you can see the appearance of the hands. It is much more wooden and then sort of thing. But he again we brought him back to Amrita, gave him a job, and then he's under our constant care. So he's retaining the hands, but in future sometime we may have to remove it when he asks for it, but I don't think he will ask for it in the very near future at all, because he's using it so well. He's still leading an independent life without issue. So, but from a 95% function, he might have dropped to around 70% function, which was unfortunate for us. Shreya is the fourth one, double forearm amputation, double upper arm amputation, forearm amputation which we converted into upper arm, and then we had done the bilateral supracondylar transplant for the first time. Now she is very well. She is back. She appeared even in the Kaun Banega Karodpati sort of with Dr. Sunil Shroff had done last year. And she is one of the brand ambassadors for the organ donation across the country. Very motivating speaker now, going across the meetings talking about organ donation, and her how she fought her way back into life by, she tried her processes. She was categorically saying that she couldn't live with the processes. That's why she went for a transplant. She was very clear. She is still very clear about what she has had. And then she is back now in the university. She was an engineering student. She felt that it is not the right thing to do. So she is back in Pune and joined the commerce stream. And then she has almost qualified. I think she is going for an MBA course now. So she did very well. We have the picture. Yeah, this is the transplanted picture, on the right side. The transplant. We have other but now she had a very stormy period. She had PTLD, and one of the worst things you can be dreadful sort of thing which you fear in transplants. Like if you all remember Peter Cavadas talking about his loss of the lower limb transplant, the one reason was the PTLD and a brain lymphoma, which made them to remove the limb and then reduce the immunosuppressant. Shreya had almost bad scenario of PTLD, and then luckily she responded to the treatment very well, and then she then developed CMV infection again. That was she responded well to the treatment, so she did well. So she gave us the experience of all these sort of things which can go wrong in a patient with the transplant. Linga Shelvi, proximal forearm level transplant, 45. She sustained this thing, transplanted in 18. She is doing well. She was a severely diabetic lady, and then that is the reason her progress had been very much quite okay. She did so well, during the post-op period and all those things. The only thing which we made slightly different was because of her diabetes. Our nephrology, immunologist, Dr. George and team thought that we could avoid steroid. If you have to avoid steroid, then you have to stop it in the first month itself. You cannot go beyond that. So we did that, and she has been doing well. She had only one episode of rejection in between. So she has been doing very well. So that was one thing but we have not been bold enough to withhold steroids in all the other subsequent patients. Sixth transplant was Prasad. Prasad had, again, lot of stories we have to tell about him. He had a proximal level on the right side and upper arm level on the left side. He had a bilateral hand transplant. We brought the hands from Bangalore by flight, commercial flight. The right forearm worked well. The left, on the second day, even the day of surgery itself, the vessels were mismatching and we were doubtful. So the second day itself it was ischemic, so we removed it. And then the problem was there was a gross donor and recipient mismatch. Even though the hands were taken high level, there was a lot of the gap between the arteries and veins. So that was one reason where we lost the left this thing. Again, one more thing I have to say in this. I will come to the last slide. When I come there, I will discuss with that. The time duration between, like, these hands were brought from Bangalore. We went to Bangalore. We had it removed, and then we had a 1 hour journey to the airport. Then we waited for 1 hour, even though it was timed perfectly well. We took the Air India flight from Bangalore to Kochi. It was timed in a way that we won't lose much time. Unfortunately, the plane was 1.5 hours late. So it added that ischemia time of 1.5 hours time. And then when it landed in Kochi, everything was okay. By the time we reached the hospital, we found that the hands were not brilliantly looking. It was not. It was, even though it was perfused and all those things. So the ischemia time also had been very high. Is Mohit there? Mohit, what was the ischemia time in him?
Actually, the ischemia time,
Yeah.
perfusion of the extremity took around
20 hours. That is something which I don't think anybody would have. We thought that we wouldn't get anything. The left upper arm was acceptable because we knew that technically it was not, we couldn't have done. Otherwise, we should have short. There was no way we could have. We should have shortened it so badly that the elbow would have been somewhere in the upper arm level, upper level. Then only it would reach. But the other one, the right hand, luckily, and then survived well, and then he's doing well. He has gone back to Hyderabad. He's a Navy guy, Navy guy. So he is planning to join back. Even with the one hand, he is very comfortable. He is living independent life. So that way he is not unhappy, but we are unhappy that we could, after all these things, we had to take the left hand off. Seventh transplant, Manega, 52-year-old lady. She was one of our favorite sort of patients waiting for to be transplanted because her story was tragic. Her husband had chopped her both hands in a sort of schizophrenic frenzy. More than that, he chopped off her both legs also, and then she was quadruple and amputee, helped only by her sons. After waiting for a long time, we got the hands from Amrita itself, and the perfectly done sort of 10-hour surgery. I think we did the both upper arm transplants in 10 to 10, maybe 11 hours. It all went off perfectly well without any problem. But again, like the Jipmer patient, 2 days later, she started having issues of, I'll come to that in the next slide. See, proximal right upper limb hematoma was there, POD2, left upper limb arterial bleed, POD3. The problem was that she started developing high tachycardia and high fever. There are two issues we thought at that time. It was a gram-negative sepsis versus cytokine storm. Cytokine storm is something where there is a load of cytokines released by the one reason here is the ATG induction can lead to that. And then there was a debate about on that day, first day, because the procalcitonin was not high on that day, even though if you look at sepsis and cytokine storm, everything affects in a way badly the whole body in the same way. So it is very difficult to differentiate. So here we treated as sepsis with all antibiotics and our cytosol. Cytosol will be something which I'll come to later in the last patient, where you absorb all the toxins by passing. It's like a hemofiltration, but it takes off the toxins. So, but she succumbed to cardiac arrest on day 5. So I will come to again the reasons in the last slide. Islam then done 2 days later. 2 days later after this lady was bilateral amputee, forearm level. He had corneal transplant for his blind eye, which was done about a year back. So he regained his vision by corneal transplant, and now he is doing well. Now it's about 1 year, 3 months, and recently, today also we saw him. He's doing very well. No issues with him. Only one episode of rejection, 1 or 2 small episodes. So nothing. The last patient is 9th one, Basavanna, 35-year-old male, electrical injury, again forearm. We got the donors from a nearby hospital. So that was, he is also doing well, but again, he had some issues which has not been put in the slide. He started developing tachycardia, the one peculiar thing which we found was that he had severe hypotension during the whole theater period, which he was on 3 supports, which was very unusual. Almost all the other patients, you might need some supports because of the reperfusion injury and there is oozing. But this patient had, in spite of we thinking that it's not too much of oozing, he had severe hypotension and had to be on 3 supports. And then someday, I think day 2 on, when his heart rate was high, and then he started developing slightly high fever, and then we went all out to treat sepsis. Procal was around 100, and then almost 4 big time antibiotics, and cytosob is something which was very, very useful. I think we should know that in a case of sepsis, if it is a frank sepsis, before the onset of multi-organ failure, if the blood is purified by removal of the toxins, there is a two schools of thought of using cytosorb between the nephrology community and the liver community, that some people believe in, some people don't believe it. It's slightly expensive, 70,000 for a cartridge. The whole blood goes through that for 7-8 hours, and then it immediately takes away the toxins, and the heart rate and everything comes back to a dramatically, there is a dramatic effect. We used 2 cartridges in him, and then the antibiotic was the highest level, and then he responded within 2 days. I think it's only the timely sort of aggressive treatment prevented any further deterioration of his sepsis. Now, coming to the last 2 slides. Yeah. Now, this is the one, like the final remarks on that. Remarks will say that the first one is working well, second one is was well within till death, third one had a chronic rejection, fourth one doing well back in university, fifth one is doing well with housework, sixth one is also doing well, seventh one expired, eighth one is okay, ninth one is just getting across. Now, lessons learned. What we learned, case 1, Manu, even though, as I told you, if we had not done that flap on that day, we might have lost him, because it would left to and we were totally inexperienced. That was the first case. Second day of the surgery is this thing we note, but we had some presence of mind to think about it and do it at that time, which saved him in a way. I think this is one of the only case in the whole world which had a free flap cover after the transplant, immediately like this, to get a cover. So that was one which I think made all the preparing, I mean the persons going to procure the hand as well as preparing the donor hand, to make sure that our skin flaps are much bigger than what is needed. So that is one lesson. Case 3, so see again, he had a brilliant result. It all went because of the lack of immunosuppression. That was bad. That was bad, and that was our fault, because from the moment he was very keen for surgery, his family was very keen for surgery, but we knew that he had economic issues. During the surgery, immediately during the hospital stay, we all had to pull in money to get him out. We created a group for crowdfunding. So I don't think you should venture into a transplant unless you are so sure about their support basis. You shouldn't, because he had a chronic rejection only because that fellow was not really a person who had taken the transplant. He and the family had not understood the whole transplant process and taken it seriously. So had they done that, they would have never, like Manu and all, knows each and every moment they are looking at the hand to look at if there is a problem. That's the way you have to teach these transplant patients, like, and make them understand, make the family understand how to look at that, how to monitor themselves, and if there is a problem, get back to us. That is the way it should be. But we've miserably failed in that guy, and that is the only reason he had this poor thing. And the moment we got him back and put him in a job, and then this thing, he's doing reasonably well now, but it could have been done earlier, or we shouldn't have transplanted even at that time, no, unless they were sure, because we had to literally beg to a lot of people to fill, get the bill paid. That was the way. So never go ahead with any transplant. So from that moment, we have made sure that, see, you are a private hospital, you have to pay. So there is nothing you can, and the hospital paid for the first transplant. It doesn't mean that it will pay for all the things. So we make sure that unless they are around 30 lakhs rupees in their thing, it is deposited. We never ever will venture into any further transplant. That is one thing. Case 4, be ready to face extremes of complications, PTLD, because it's we had Mohit and a whole team had nightmarish days of this one, having PTLD being detected in that girl. But timely intervention with a very knowledgeable support from nephrology team, our medical oncology team, hematology, Dr. Neeraj, Dr. Pavitran, all chipped in so well with a highly knowledgeable guys. They are all brilliant in their field. And then this patient had unlimited financial capability and family support. That is what saved her. So again, lesson learned was things could go wrong, things can go wrong, but there you have to have the right way of thing to support them. It doesn't mean that it will see PTLD. This might have been maybe one or two in the whole world literature about composite tissue transplants. So, but you should be thinking of those things when you are when you have these issues. Case 5, steroid-free regime is possible, which I told you, but are we ready for a steroid-free regime boldly in all the other cases? No, we have not continued with the steroid-free regime after that, because we, again, everybody is a bit wary about it. Like, are we doing are we bold enough to do that? Maybe we should be bold enough because she is doing well. There's no problem at all. But one theory is that why Dr. George and team said that we will go steroid-free, or that her diabetes was long-standing. That would have made her immunocompromised for a long time. So you don't need that much of immunosuppression. That was a theory which worked well for her. Case 6, ischemia time, as I told you, we brought from Bangalore. This taught us a lot of lessons. We were frustrated because 1.5, 2 years there was nothing happening in Kerala. There's a huge hue and cry about organ donation being mafia controlled and all those things. So nobody was coming for an organ donation. So we were all frustrated so badly. That was what we made us to venture into other states. And there was one very good coordinator from Bangalore, Dr. Lija. She's the chief coordinator now in whole Bangalore. She got us this donor. And then this was a long distance thing. In a desperation, actually it was a desperation thing which we went there in a way. We went all the way. We took routine things, and then we harvested and brought the patient the organs back in a routine flight. Unexpected delays can occur there. So I don't think you should venture into long distance donor transport, unless everything is meticulously at your hand. You know that things won't go wrong. I would today bring a hand from Bangalore only if it can be transported by helicopter. Simple factor, because that is under our control. You can land and things. So you shouldn't do it otherwise. We are thinking of there is a can it be transported? You can be transported, provided it's a single flight and it's not. There is Ahmedabad, there is a lot of donation happening. There was ready to donate hands, and there is a direct flight from Ahmedabad to Cochin. So when you are looking at the logistics, you might be able to get the hands from Ahmedabad and restart the perfusion in about 5 to 5.5 hours. So if it is a distal forearm, I wouldn't mind do that. But look, in Prasad, we took a very bad step of bringing an upper arm from that place. That too with a mismatch of size, which was again a disaster. But now what is a solace is that he is so happy with his right hand. And then it's working. It has regained even the intrinsics. At that level, it has regained. Even after that much of ischemia, it is regained. So that is giving us solace. But lessons learned was that if you want to bring something like that, you have to really be sure about how you are going to bring the thing, and what is the time involved, and how will you bring it. Case 7 was like Jipmer, unexpected things can happen. Now, this theory I also fully agree. Quadruple amputee, body surface area is less. The immune load by adding 2 upper arm transplants in that might be high. It is not like a full body. You are doing it to a half body, because she was a above knee amputee, and then ATG induced cytokine storm versus sepsis is something which you all, whenever you continue with the transplant business in future, you have to keep this in mind. This can be deceptively, confusing. It can be really confusing to look at what is the problem. Is it a cytokine storm or sepsis? Here only I think we might be able to do it better. We have undergone the whole process now once. So we might be able to detect it better and do that, but keep that in mind. And then the management of this. Now looking at it, could we have done better in her? Our whole process was quite good, and then she was always, for her whole life was centered around this transplant, and her son was sacrificing his whole life for looking after her, and their only wish was that she had her hands. So we were all very sad about it, but looking at it, we did the right thing for her, but maybe physiology did not allow us to get successful. So the quadruple amputee having all these things, you remember the history of the leg transplant with the hand, composite. If you add more and more tissue, there can be problem with the body. So that is a factor which you have to think in these patients. But again, this was an upper arm transplant, and she had a bilateral upper leg amputation. So keep it in mind. Lastly, case 9, as I told you, early sepsis, laxity. We thought that we were looking back. See, unless you look back at your own problems, you will never learn. And you have to be bold, and in this thing, you have to be frank and bold. What is the thing? And we looked at it, and then we thought that there could be some laxity in the preparation of the donor hand, because this patient literally had a arterial line. So before not the patient, I mean the donor. So whether we were really meticulous in getting it, I think, because even small area of contamination can lead to colonization and sepsis. So I'm not saying that is the reason, but look back at your problem. And then now we have made a flow chart. Now our job next day was to make a flow chart. What will be the whole thing which you are going to do in the next patient? Next patient, we have decided that we will thoroughly wash the donor limb. Make sure that who are going to harvest will also prepare it meticulously, and then before putting in the ice bag, we'll wash it. When we come back and then do the preparation, we will wash it. Then only we will use it. So whether that is the right thing or not, right reason for the problem or not, we were making sort of amendments in that. This was the first time it happened, so it doesn't mean that this is the all the other people. Other people might have been sort of lucky in a way that nothing was contaminated. Aggressive intervention is very, very, very important, which we learned from this patient. Unless we all had put in our minds together and then see that 25 lakhs in our hospital made a difference. The patient had 25 lakhs in his account in the hospital. So you could go ahead doing something. If it is a poor patient, unless it's a Jipmer type of situation where you can use anything, that it becomes different. So aggressive intervention, cytosoap is expensive, antibiotics are expensive, but that aggressive intervention helped. And then I would lastly add one word about Hemarina, which Mohit will elaborate later on. I think we are too early to talk about it, because we use that local oxygen carrying one solution which was provided by Dr. Lenteri, who might talk about the Hemarina in his talk today. So we are not still sure about how much it has helped, how much is a issue. So it might be one solution for long distance transport. So we will come to that later. So let me acknowledge my whole team. Vasundhara prepared it, but she didn't put their photos, the fellows' photos, because they are they are one of the pillars of the team, all the fellows and people. Yeah. Last slide, it is there, is it? You didn't forget. And the immunosuppression team, intensivist Subair, and the rehabilitation, Prasad and Malini, and these are the fellows. So all the fellows, oh, okay, yeah, everybody is here. Everybody has gone through the whole process. So thank you very much. Yeah. Anybody there? Jayakumar and Selva?
Yes, sir. Yes, sir. Yes, sir.
Yes.
Yeah.
Great, sir. It's a great presentation. And you just compile it very nicely, giving all the things, and especially the last few slides where you mentioned the lessons learned.
Yeah.
In an Indian scenario, I think these points are very, very valid. I think yeah, the future who are going to do, I think they can learn a lot from your overall surgical technique as well as these points which are not never in the books.
1 minute. So, yeah, I think Selva, we all have to be really, because this is a nascent stage of transplant, and then let the thing, if you look at what has happened in the country, in the transplants, if you look at the foreign countries and our country, the people who have gone back to work and gone back to independent life, I think we need it more than many other countries, because the people, the social support, other things are so bad here. So what we are doing by the transplants, in spite of the hiccups and all those things, by our experience, see 9 cases experience, we will be a very good team now, because we have gone through the whole hellish sort of complications, if you could say that. But the only thing which redeemed us was the team, and then lot of people to support each other in a way, and then that has made us refine ourselves in the next transplants. And then I don't think we are ever thinking of going back and then not doing. And looking at the cases which flocked to us, see, we have about another 6 patients just there waiting outside the hospital. We have another 20 people who have been listed in the thing. So there are a lot of people who are there. So I think for Indian scenario we should go ahead, but then we have to put our heads together and then look at our problems, and then only we will overcome. See, you all can learn from our mistakes. Unless that openness is there, we won't go far. But we need lot of more teams doing it in a way. So I'm not saying that it's a panacea for anything, but look at what is the scene of the prosthetic hands. It's dismal. You cannot have to anybody that most of the people will talk theory and they will live without hands. That's all. So if Jipmer can do it more with sort of, it is a government institution, Stanley is a government institution, so social this thing, financial thing is not there. Amrita is a private thing. Still people are ready to get money and do it. So I don't think that is an issue. Mohit, why I asked is that, see, when is the Lenteri lecture? How much more time?
We have to start Dr. Jelena's lecture at 4.
What time? How much more time is there?
We have just 20 minutes.
20 minutes. So what I was thinking was that I was supposed to do the panel in the end. We can next 20 minutes. All of you are here. We will discuss the Indian scenario. Let us finish off that in 20 minutes, and then we can start with Jelena and then Lenteri and finish off. Is that okay?
We have
20 minutes, that's enough. We are discussing all our problems now. So my point of that panel was, what are the steps we should take? I think the first thing which we should take is the openness and then boldness to come out with the experience. There should not be. But Mohit was, I think, a part of the Mumbai team where and Selva, both of you were there, and recently there was a case in by Vinita also. So everybody had some issues. Those issues, many of them could be corrected by more meticulous sort of planning. That is what I was meaning by the, how should we proceed in India? Is there anything we can collectively do to improve the scenario? What should be the way we should be thinking in terms of, getting the hands from different parts of the country? Can look now if there is a donor in Chennai and the recipient is in Cochin, why should we have a team come from here to Chennai? There can be have a team in Chennai who can procure the hands, bring it to Cochin, or you can have a team in Ahmedabad to do that, or with some person doing that, and then it will, when the local people are involved, more sincere efforts, and but they should all be trained. That's the only thing. They should work together that way. So that is one thing we have to think about. Any questions or any comments you all can give? You please do that.
So what is the cost of Cytosol totally?
Cytosol was 80,000 per capsule. Cartridge.
Cartridge.
The machine is there in the hospital. I'm sure most of the renal transplant guys they will have. So cartridge is 80,000. We use 2 cartridges.
Sir, can I talk, sir? Dr. Ramadevi, sir,
Oh,
from Chennai.
ma'am. Yeah. Please.
I just joined. I listened to your talk. Very nice to hear all your experiences, sir. So the suggestion what you have given, as of my experience, what I've gained in one transplant, this being a government setup and that is a private setup, from here to there, if we procure the hand and send it there, it will be a question from the government why we are not using it here. So if at all it is made as a national program and a common list is made, we cannot do like this. That is what I feel. Even in between Jibmer, they were asking for some hand donation from here. Whether we could do it or not, we were in a dilemma, and government did not accept us sending the hand from here to there. That is what is the problem. So if it is made as a GO in between, which makes it clear for everybody, then it can be done like that.
No, yeah, I fully agree to that. See, when we are talking about this transfer, when we had this initial, Dinesh knows about it. When we had this, the first transplant from Bangalore, our patient was a foreign patient. So naturally, there's a rule that Indians should be given preference, and that's how. And then if there is a patient from the same state, they should be given preference than the other one. And if there is a patient from the same blood group, they should be given preference. This is all based on what has been in practice for the other organs. What I had been discussing with Dr. Vasanthi Ramesh at that time was that hands, hand teams are less, hand patients are different, and even if Dinesh or Jayakumar has a patient, it might not be possible on that particular day to take that hand. That is a problem, because do the case, because it's not like a liver transplant where everything is there, or renal transplant. Unless everything is ready, you cannot accept a hand and do that also. So what I was suggesting was that we should not have too much of sort of preconditions to put to like that. So if it is open and then you say that it is not possible, everybody should be ready to say whether it is possible or not immediately, so that the other teams can be ready. So what you said is right. We need to have a national sort of thing. I would have suggested that, look, we have listed 6 cases. That thing should be known to everybody, all of you. You have listed 3-4 patients, which should be known to us also. So what is the problem there? Because there is no need of looking at, like, I need not ring up Jayakumar or Dinesh about are you having a hand like that and this thing, because the people consider hand as same as liver or kidney, which cannot be. We all know that it is not. technically and otherwise it is very difficult as an organ. So there I think we need to exchange these lists and all those things frequently, maybe monthly basis, so that we can all help out.
Sir,
Yes,
good
sir.
afternoon, sir.
Gobi.
Sir, good afternoon, sir.
Yeah.
Firstly, sir, thank you. Excellent the presentation. It's always inspiring to see your lectures. Huh? It's beautiful, sir. Sir, I have something to contribute. What happens is, sir, most of us are very individually motivated. We see that you have an excellent team. We earn and we respect such teamwork, sir, which we, it's very difficult for us who are running to get a team. Even one person is not enough. We need a whole set of team. So the team training and team motivation becomes a big factor when we are trying to perform a transplant in our scenarios, sir.
Yeah.
So that concept must be to get the team, not just one person. It's the entire team that should be trained and motivated to get that, sir. So the team training building activities, somehow we have to coordinate so that we have teams. We are known by the teams and that they can look after that, sir. Though it's led by one inspiring leader, but the team is essential, sir. Second thing is transfer. As madam has already said, we need some law. I think with time, more and more transplant being done, with time, this will come in route that we can shift hands, because then more and more understanding will be there. I think time is the only factor before we realize that this transfer is possible. But the another glitch is there, because when a team tries to do a transplant, it wants the hand, like you said, wash it. You have your own set of protocol before you can accept the hand. So that also should be generalized and say, these are 10 steps that has to be done if we have to accept a hand. You being the prolific center, only you can direct us, because we are very sporadic. And when we come and even come near half your cases, then probably we can contribute to that. But otherwise, it's your protocol that we have to adhere to and make sure that we do it as in a good way, so that the hand can be transplanted onto a better hand, sir. Third and my final point, sir, is like, what is your opinion unilateral? Because you are the institute which has to lead by unilateral. If you do even one unilateral, it can be we can justify, and because there are many unilaterals that come. So if you can do wherever it's indicated one unilateral and show us, we can always go ahead with our unilateral, sir.
Gopi, I will just add to that unilateral thing, because I see when we started, and we are not listed unilateral because of the number of bilateral we have. But I don't think we should be too much dogmatic about it also. Like, if you are comfortable in doing a unilateral, do it. Please do it. Then you will be much more comfortable with a double hand. So the fact that we have always been advocating double hand transplant for various reasons. But I think we should also, I will also stop saying that in public too much now. So otherwise, people will think that that's not the right thing to do a unilateral. It's not that. It's a right forearm and then patient. It's not left non-dominant, you might be thinking. Yes. But right dominant hand, if you have some patient and then do it, well, go ahead and do it. I don't think anybody should be shy about it of not doing it. See, our sixth patient, Prasad, he is so happy with that right hand which he has. So yes, it is not something like that way. Second thing, I think, Gopi, you have to reawaken the armed forces movement.
Yes, sir.
You can't. I mean, see, I told you, see, we have listed our problems. We have faced, and we have been continuing with that, right? So it is not something like we need to know.
So there will be a time, sir. There will be a time. We have to go through the rotation. So with that rotation time will again turn and the program will again reinitiate, sir. It will come up good, sir. I assure you that.
I think, when we looked at it, the armed forces was the best place to have a huge transplant program. Everything is there. Donation is there, automatic. Transport is there. So nothing else would have been more congenial than yours.
Yes, sir. But there are many more other factors, sir, which we cannot discuss it. But I'll we'll discuss it private, sir. Thank you, sir.
Mohit, see, Mohit.
Can I add a few points, sir?
I have just one more thing to add in this. Sorry, sir. Come. Just one more thing to add, that with the global hospital in which I was also part along with Selva, I think the technical feasibility has been proven that it could be done like this, that one team can fly to help other team members. So it is it is very much feasible. We worked that thing out that we should be able to help each other in the case if some now connectivity is not that much an issue. If at the first apnea time you can get some guideline that we have to come. So I would say that this kind of inter-team collaboration is the key.
Absolutely, sir. Absolutely, sir. We look forward to that, sir, and thank you, sir.
Can I add a point, sir? Hello?
Yes, Selva, yes.
Yes, sir. Actually, within the global team, I think a lot of things, because it's the same organization, we had a lot of things that overcome so easily. But regarding as Toby pointed out, regarding the number of people who can help us, what I have done in my hospital is, we are only 4 full-time consultants, which is definitely not a required team. So what I formed is, I formed around 10 members of doctors who are good in hand surgery. For example, Purushottam there, Krishnamurthy, and even if you remember, I think long back we got your CV also. Iyer sir and Mogi Sharma's name is also in our hospital. So I have already formed a 10-member team and given to the hospital, which they have approved. In case of any emergency, so probably I will share all the patients who are listed or interested. One patient is really interested in some regular follow-up. I'll share the details. So all of you will be knowing the details. In case, definitely my team alone is not sufficient for this. So we can call any of this among the 10, even 6 members come or 5 members come, it will be much easier for the whole procedure. So that's what I have done with the hospital has also accepted that proposal.
I think that is a very, very valid thing. See, if you look at Nilesh's case, presence of both of you helped a lot, which he also acknowledged, this way. Mohit was there to support some sort of issues, which makes a difference. I don't think we should be shy of requesting for help from same town or different towns. Or transport is not a big problem. Expense is not a big problem when you have a shortage of manpower. I don't think that is some big. I think that is one good suggestion that we should be able to do that. But that needs institutional sort of thing, because government colleges might not be able to take in private people. All those things, army might not be able to get in sort of thing. But if you can work on that beforehand and get a preemptive sort of this thing, permissions and all those things, I think that is one step we should do. So that, see, hand transplant occurring in anywhere in India is a sort of episode, even episode in the media, episode in the everything, everywhere. It's something which carries lot of weight across the world. Anything happening also. So I think we all should be good enough to be as a single family, like you should be able to help out and then give support also if there is anything. So that I think we have to look at it.
Hope Selva will include me after my retirement, sir.
No, actually,
anyway, I'm out of Stanley now.
No, it's not like that. Even now, because even now I can include that time.
We'll join Global.
Yeah.
Not in Stanley now. So I'll join Global.
So hospital name suggests we can invite everyone. It's a Global, don't worry.
Thank you.
The transport business, I have done a lot of research on this transport business now. Like the line, they have been transferring heart and all in a commercial flight. But the problem, the good thing is that the preservative and all those things are different, slightly different. For us, I think the level of hand that is being brought in makes a lot of difference. If it is a proximal forearm, upper arm level, I would still prefer to have it from within the area, right? Summer area. But I think we should think of getting more organized, and then direct flights, which again we have to talk as this thing to. Our society can talk to airlines are only few numbers, that if it is there, will they give priority? Now, can you I don't think it is a nice thing to transport this hand in the cargo compartment of the plane. We don't know what is the situation there. So, but then this is the problem is Dr. Janji, welcome. Hi.
Hello.
Our guest speaker is here, so I would request Mohit to introduce her and then get on with her talk. Thank you very much for accepting our invitation.
Thank you for having me. I'm very honored to be here.
Good morning, Dr. Yelena. Welcome.
Thank you.
I would introduce our esteemed guest speaker, Dr. Yelena Janich. She's an associate professor of pharmaceutics at Duquesne University, Pittsburgh. She will present the extensive collaborative efforts with Professor Vijay Gorantla, Winston Salem, who is also current ISVCA president. Dr. Yannick is a founder of Chronic Pain Research Consortium, and she has 16 years long expertise in imaging and drug delivery nanotechnology. She will present her joint work with Professor Gorantla, who currently work together on new biomaterials and nanotechnology in VCA, from nanoimaging to nerve regeneration and organ preservation. For this session, our chairperson would be Dr. Kishore. He is a professor at Amrita Institute of Medical Sciences. And I welcome Dr. Kishore. And I welcome Dr. Yelena. Thanks for taking out time for us. And please enrich with your great experience. Welcome.
Thank you again. Thank you so much. I guess I can share the screen now.
We can hear you. Yeah.
Should I share my screen?
Yes.
Good morning, everyone. Well, it's morning in the United States. I think it's afternoon over there. Thank you so much for having me.
Thank you.
I was asked by Professor Sharma and Professor Gorantla to present our work today that covers a couple areas that are of interest to your audience that's very interested in VCA. So the topic that I'll be presenting today is actually emerging insights and future perspectives in VCA. The actual focus would be on advanced technologies and nanomedicine that we work on. I do hear myself in an echo, maybe. Well, I'll continue. I don't have any conflicts of interest. So VCA program, as all of you know, has been rapidly expanding and has been benefiting many patients. I was fortunate to meet several patients, in particular one of Professor Gorantla patients, even before I actually met him and started doing research. So VCA is a very complex transplant paradigm, and the goal is to improve quality of life and avoid repeated surgeries and reconstructions and minimize morbidity in people who suffered severe injuries like this fellow that I'm showing here. The mission of our lab, joint work with Professor Gorantla, is to improve safety, benefit, and outcomes for patients. We focus on 4 areas more broadly: non-invasive imaging, tissue and organ preservation, targeted immunosuppression, and neuroregeneration. There are 4 major challenges, both clinically and in research, that we are trying to address. The first challenge is to try to understand the immune response upon transplantation and also monitor the patient compliance, and the immunosuppressive therapeutic regimen's effectiveness. The second area is tissue and organ preservation. That area is more recent for our lab. The third area is local and targeted immunosuppression. And then local and targeted immunosuppression is definitely of high interest, and our lab has recently partnered not only with Professor Gorantla, but Professor Vemula from INSTEM in Bangalore. The focus of my lab over the last decade has been applying theranostic nanomedicine to a variety of disease states, from chronic pain to immunomodulation in trauma and other chronic diseases. But more recently, we started working in VCA. So theranostics, if you haven't heard of this area yet, but I'm sure you did, is a very broad collection of nanotechnologies that have multifunctionality, so they can allow you to deliver varied payloads, provide you maybe sensing capabilities, imaging capabilities, allow you to target specifically to the areas of interest where you want your therapeutics to reach. But ultimately, which we think is very beneficial for future use in VCA, is that you can actually personalize this treatment, and you can select specific patients where the treatment continues or change or adapt. And you can do that in real time. As you know, VCA patients not only are unique from each other, but they actually experience changes in their bodies over time, and no current treatment can quickly adapt to those changes. So theranostic nanomedicine is very complex effort and requires multidisciplinary collaborations, and this is how Dr. Grundle and I started working together. So it involves chemistry, biology, nanotechnology, medicine. And two of us actually co-edited a special issue on this topic where we were trying to promote bringing new technologies to VCA and the reconstructive transplantation. So I can invite you to read one of our forewords, which is actually the thematic underwriting of the entire talk today. In essence, we're looking into expanding nanomedicine into multiple areas of VCA needs, from diagnostics to better therapeutics. If you look more closely to our efforts, we are really trying to engage the immune system in multiple ways. So immune cell targeted nanomedicine is more recent development. You probably heard of some of the examples that are trying to support immunotherapies in cancer, but we think that in VCA there is quite an untapped potential. So whether we're looking at immunomodulation in the blood or the organ itself, the nanotechnology offers persistent stability, conformational integrity, and so forth. And we also have access to a variety of imaging modalities, most importantly, combining multiple imaging modalities. So you can imagine looking at treatment in multiple ways, non-invasively, and also treatment response. So there is a huge promise of nanomedicine and theranostic nanomedicine in VCA in particular. It allows you tunability, versatility, and multimodality. But there is also the opportunity to deliver sensitive therapeutics, whether systemically or locally, whether it's DNA or oxygen or small molecules or RNA. The active principles can be protected long-term from the enzymatic degradation, for example. Allows you modification of pharmacokinetics and pharmacodynamics. Very attractive opportunity for VCA is specific organ targeting, where the treatment goes only where it's needed and doesn't give you unwanted side effects, as you are all aware of. So targeting specific cellular compartments, adaptations to each patient. However, there's still many challenges in this area. And development pathways can be complex, And my lab is particularly interested in reducing the cost and complexity by improving designs and improving manufacturing strategies. We're also very keen on maintaining a high level of safety, whether it's the patient in the future or someone who actually manufactures these systems. Patient adoption and adherence is still a challenge. Nanotechnology for most common patients sounds kind of scary. They might not want to engage. So there is a huge need for increasing awareness and also continuing to improve safety. Manufacturing and GMP production and scale up are primary bottlenecks for a lot of nano systems out there that are trying to reach the clinic, so VCA would not be any different. So our lab over the last decade has really worked in a strategy that's more platform based, so we don't really focus on developing individual products for every application. We try to actually incorporate this plug and play customizable design, and this is how we entered VCA field several years ago, because we could offer multi-drug delivery, oxygen delivery, multimodal imaging. And here's just two examples of our areas of interest from the technology point of view. Biomaterials that can be implantable, imaged in the body, can be used for controlled release, reduce systemic exposure. And all of our efforts really are utilizing this quality by design strategy, which has been adopted by pharmaceutical industry for quite some time, but it's just more recently reached into nanomedicine, where we basically start building predictive models, incorporate machine learning to best understand which product fits the best for which application, and how we can actually design in advance the features that we want, specifically safety, efficacy. Can the material be scalable? Can we produce it? Can we have reproducible production, so we can actually reach in the future every patient that needs this type of technology? So I'm going to break the rest of my talk into these 4 areas and how we try to address them, the challenges in VCA. Non-invasive graft immune surveillance or imaging is a huge need. Currently, you're still relying on imaging modalities that might not penetrate deep enough into the tissues. You might rely on biopsies, which they're invasive and can present as a challenge for maybe triggering inflammatory response while you're trying to assess it in a VCA patient. So nanoimaging is a major area of effort of our lab, and we collaborate with Professor Grantla in this area extensively. The primary target of our nanoimaging efforts are macrophages. You know of these cells, they're primary responders to injuries. They're also drivers of both acute and chronic rejection. So monitoring macrophage behavior in a VCA patient would be highly beneficial, especially if you can track them into deeper tissues and you're not just limited to close to the surface, skin, and areas. Monocytes and macrophages have been extensively explored as a nanoimaging target in a variety of inflammatory diseases, and we work in this area: rheumatoid arthritis, inflammatory bowel disease, infection, trauma, TBI, and stroke. They're also important targets for controlling and supporting neuroregeneration and wound healing. They have a role in organ preservation, and importantly, we also looked at them and our collaborators as the target of developing better immunosuppression strategies, particularly in VCA. I apologize, my slides keep to jump ahead of me. In VCA, as you're aware, there is an extensive activity of monocyte-derived macrophages, and they would be, more importantly, they can change their phenotype, and this is why we are trying to engage them both therapeutically and diagnostically. So in our earlier studies, this is one example. We started with mice. We induced inflammation with something called CFA, or complete fluid adjuvant, injected into a foot of a mouse, and then inject our nanoparticles. These are near-infrared fluorescent nanoparticles that are specifically phagocytosed by macrophages. And then what they do, it accumulates, as this figure on the bottom here shows, as you see red in the gray background of the X-ray image, the red represents the increased inflammation, which is correlated to increased infiltration of macrophages. So this was the starting motivation of moving this technology further into VCA, as you will see. But also we have multimodalities in our nanoparticles. We can excise the tissues or do MRI in living animals. And this is an inflamed leg of the mouse. What MRI allows you to look into deeper tissues and also quantify the presence of these cells in real time, which then could serve as a surrogate outcome measure for your anti-inflammatory treatment or your immunosuppressive treatment. So when Professor Grantler started to work with us, he first took the same paradigm but moved it into rats, and then they extended their monitoring to about 3 weeks. And you can see that this green is actually our nanoparticles accumulated in the limb that's inflamed. So over time, the signal starts increasing to about a couple days and then it wanes away, which actually is representative of flows of macrophages into the area of inflammation. In our earlier studies, we did explore combination of MRI and near-infrared imaging, and this was a cancer study done a little bit earlier, but I'm giving you this as an example that combination imaging is very beneficial because near-infrared imaging is relatively cheap in comparison to MRI. So it can give you this initial readout of inflammation changes. This is tumor inflammation. And then you can verify this, look at the organ distribution and other areas of interest by fluorine MRI. And this is our standard paradigm in our lab, combining these two modalities, and as you will see later, combine them with drug delivery. So this is the first example of VCA imaging, and I'll walk you through this. This is hind limb transplant model that's developed in Dr. Gorantla's lab. So what you see in the first series of images is the clinical picture. So as this rat did not receive any immunosuppression, this rejection sets in pretty quickly. And you can see in the lower series of images, as the rejection becomes worse and worse over time, the presence of signal increases, which corresponds to increased infiltration of macrophages, which we are tracking with these nanoparticles. If you look to your left, this is a composite assessment of the same rejected limb by fluorine MRI. And it's very obvious that anywhere you see red is your nanoparticles labeled macrophages. And now you can detect signal much deeper into the tissue, you can go all the way into the bone, and you can get very accurate assessment of inflammation, and also allows you to look at the entire limb in the 3 dimensions rather than just surface. So these are different sections by MRI through the same limb. Dr. Grantler also has a face transplant model, and we tested this near-infrared imaging strategy in that model as well. As you can see in this rat, anywhere you see increased red or green corresponds to increased signal, which also corresponds to macrophage infiltration. So this is applicable to a variety of VCA models, and we're exploring several of them. I'm giving you here just 2 examples. Also, this strategy allows you to understand the biodistribution of the nanosystems and see whether macrophages actually infiltrate other areas and whether that would change. One thing that we saw in our lab in inflammatory models is that changing response to inflammation changes the presence of macrophages in the spleen, and we think that has relevance in VCA, and we're exploring that further. The second area of challenge in VCA would be organ preservation. And it turns out we have actually already been developing technologies that have oxygen delivery capabilities. And we are starting to look at how these nanoparticles could be more of an advancement against current state of the art, including University of Wisconsin solutions or whole blood. These nanoparticles are shelf stable. They can actually deliver oxygen to tissues in more predictable manner. And it turns out, though nanoparticles have been used as blood substitutes in oxygen delivery systems, they haven't really been extensively explored in VCA, and they can be used in combination with some other strategies that are more well established, particularly with the cryopreservation or hyperbaric approach. So we are exploring our nanotechnology, which is based on perfluorocarbons, known blood substitutes, for organ preservation in VCA, in also exploring that both in cold and warm paradigms. It is a very complex system. VCA is a complex transplant, so the nanoparticles will have to perform in variety of tissues. And to meet that challenge, we are applying what's called quality by design approach. If you haven't heard what quality by design approach is, it's a risk-based approach of engineering, and it has been adopted back in late 2000s to improve quality, to build in quality and safety at the design steps. And it usually involves an iterative process where you create libraries of nanoparticles, test them in a particular model, feed that back into your mathematical models, and continuously optimize. So on your right, you see a table of what we called a quality control attributes. And these are some parameters that we're trying to control for our nanoparticles, and these features are tied to their performance. So recently we published a novel nanoparticle system which allowed us to explore a relationship between oxygen delivery capabilities and colloidal and other stability profiles of these nanoparticles. So here you see a graphic of perfluorocarbons interacting from donor droplet to the aqueous medium, and this is how oxygen will travel. We can load up the nanoparticles with oxygen and monitor release over time. But most importantly, we found that we can actually control this feature of their oxygen loading and release, and we can actually build predictive models of that behavior, which help us optimize specifically for VCA this technology. Interestingly, we tested this was a couple of months ago, so you see it's unpublished. This was tested actually in Dr. Grantla's lab and our lab. We took these nanoparticles and we run them through a rat limb, and we found the nanoparticles maintain their structure. They are very robust. They don't change being heated at very high temperatures for a couple days. They can be actually stored at low and high temperatures. They have very high loading of oxygen compared to aqueous media, which means they would have superior oxygenation to some other types of aqueous media that's currently used. And very importantly, whether they're run through the pump that's used for preservation or the limb itself, they really maintain their integrity, which allows us to reuse them. And also these nanoparticles are designed to not stick around in the body, but just deliver oxygen and leave. And we're currently testing this in a limb preservation model in rats. The next area of VCA challenge is, of course, immunosuppression. These people are typically requiring either steroid or other systemic treatments like tacrolimus long-term, which can cause severe side effects, both neurological and kidney toxicity and other issues. And to combat that, many labs, particularly Grantla Lab and Vembula Lab and many others, are looking at how to control this immunosuppression process and localize it to the area where it's really needed and suppress systemic side effects. And we also joined them initially with our imaging technology to try to help them to understand the efficacy in vivo, but then we also further expanded to targeted drug delivery. So if you look at immunosuppression, the first paradigm is, of course, high dose of steroids. Then the next area of exploration will be development of calcineurin inhibitors, and this was absolutely transformative. However, there are biologic therapies and other alternatives that are currently explored, and this last area is graft-based therapies, and that's where we are focusing on, which is promising to be more cost-effective, safer, avoid systemic effects, but also allows us for full personalization and full control of how the limb or other VCA responds. So why targeted therapies? These are very novel strategies Professor Grantler worked on for several years, and we more recently joined them in this effort. The idea is to minimize or eliminate completely chronic immunosuppression or systemic immunosuppression, improve the quality of life, and improve lifetime of the graft itself. So one of the technologies that Dr. Grantler has been developing with Dr. Vamula and Dr. Karp from Harvard in collaboration with United States Air Force is this GELIT platform. GELIT is a very elegant strategy which actually allows the drug delivery system to respond to the changes in inflammatory state of the limb. What that does is only in the presence of inflammatory cells the drugs is released. And this allows not only personalization between patients, but also adaptation over time in the same patient. And as you know, patients are not static, they change over time. This is a very nice approach. They have tested this paradigm in a pig model, and they found that they can control the release of the drug in the limb. They can completely reduce systemic exposure. The next example of local immunosuppression involves prodrugs loaded into hydrogels. This was done by Professor Mooney at Harvard and tested by Dr. Grantler and Winston-Salem. Here you have a prodrug linkers, and you can actually tie these biomolecules which can respond to physiological conditions. So the idea is that in these paradigms, the graft itself would, by its own state, whether it's healthy or starting to experience rejection, controls the drug release. We are now looking to adopt our earlier developed strategy for controlling inflammation by IV injection of particles that are specifically targeted to macrophages. This was done back in 2015, where we actually used a very well-known COX inhibitor, celecoxib, that can change the macrophage behavior if delivered directly to the macrophage. So on the top left, you can see images of inflammation in a mouse. The same model as shown before. But if the nanoparticle is exactly the same nanoparticle carries the drug, there is less inflammation is imaged by near-infrared imaging. And we found that our nanoparticles associate directly to the intracellular target that we are engaging in, which is a COX-2 in a macrophage. And it turns out this change in infiltration pattern is also there's a consequence of this. There's less of pro-inflammatory mediators at the site of injury. Now, at the time, we haven't looked at any other measures. So when we took this model further and looked at over 40 days, I'll walk you through this relatively complex slide, we found that there is, of course, inflammatory pain that develops in these mice, but more importantly, a single dose at the time of injury maintained 30 days anti-inflammatory action and 30 days pain relief. Now, you wonder how this relates to VCA. What we are trying to accomplish here is to have very infrequent dosing. So if you take this further, you can imagine that this patient would see this treatment maybe once a month and maintain this inflammatory control long term. More importantly, and this is unpublished data, and we're working on this currently, Grantler team was able to see that in mice that experience this inflammatory insult, there is fibrosis that develops. But more importantly, the nanoparticles were able to suppress that fibrotic tissue development. And we think that this strategy could not only reduce inflammation and pain, but also reduce other outcomes from prolonged inflammatory processes. So we take this further and now started to explore how we could take this delivery strategy and incorporate immunosuppressive drugs. So this is very new data, and we're currently testing this in animals, but we're able to specifically create these immunosuppressive macrophage targeted nanoparticles. So I mentioned quality by design. It's applicable here as well. Again, any complex delivery strategy would benefit from this approach. We create libraries. This is one example of our libraries of nanoparticles. We decide how to control their parameters and what we should be changing in order to achieve particular targeting, release profile, presence in the area of interest, like the limb, minimize the liver uptake and so forth. So looking at the features we want, we can build predictive models and control that. So variety of our nanoparticles are designed for different live studies in animals, whether it's a rat or porcine model or more recently monkeys. So any of the nanoparticles we create undergoes extensive quality control in vitro and in vivo. And there are two reasons. Number one, safety. Number two, efficacy. And number three, maintaining consistent results when we're trying to understand these immunological responses. So this is just an example of our complex nanoparticles and how many tests we subject them to and try to see whether they are changed, high temperature, exposure to biological media, and so forth. So the models that I mentioned look something like this. We first do risk assessment, and then we look at the variety of manufacturing strategies, and then we build models where we can predict either drug loading or stability, or more recently, biological function. The last but not least is our novel areas of research that involves biomaterials. Now, this is a complex slide. This biomaterial is actually MRI visible. It's thermoresponsive. It can be implanted under the skin or put topically, and it has very nicely extended release profile. We can control its rheological behavior, and this cross-linking patterns within the matrix allow us to tag it with variety of targeting agents or prodrugs. So we're currently exploring this new technology and how it could be applicable to VCA. The nerve regeneration is one of the major challenges in VCA, as you're all aware. So how can you actually support that? And how can you support neuroregeneration to maintain sensory motor recovery? How can you actually support that? So it turns out that macrophages are primary targets for that effort. Macrophages infiltrate the areas of nerve injury early. They help jumpstart healing, but a lot of times they might stay there a bit too long. They don't shift from M1 to M2, and then you now have excessive inflammatory processes. And what we are trying to do with our controlled drug release strategies, intercept this process and move them at the right time from M1 to M2. And we first worked in nerve injury models before we started exploring this more recently in VCA. So back in mid-2013, 2014, we partnered with a collaborator at Duquesne University who has a nerve injury model. And the first thing we were able to see is that we can label and track macrophages over time. Of course, we look in tissues and confirm that our nanoparticles are really there. So if you see this very bright green piece of tissue, that's actually inflamed nerve following chronic constriction injury. It's a sciatic nerve in a rat. Now, consider this moving into VCA. We could image this process very easily. But the next step on this development is to see whether it really can change the M1 to M2 phenotype. And in this particular model, we were able to demonstrate that. So this is a pain model. So what you're looking at here is a pain relief over time. So we inject the nanoparticles about a week after injury, and we see dramatic pain relief when we have a COX-2 inhibiting nanoparticle versus the drug-free nanoparticle. But most importantly, looking further down from the injury, we were able to see that we changed the phenotype. And that phenotype change actually led to other cascade of events. So in a nerve injury, we found that polarity can change, and by that shift, indirectly affect other immune cells. In particular, here we were able to see that at the sciatic nerve injury site, we were able to change the granulation of mast cells, which are also very important in driving neurogenic inflammation. So if you think about it, if you did a limb transplant, there is nerve injury involved, and you want to support that recovery. So Professor Grantler suggested that we consider applying this approach to VCA, and we're currently exploring that. When we look at tissues more deeply, also important for VCA, what we saw in this model is reduction in cytokine production. These are primary drivers of inflammatory response, and of course, acute and chronic rejection. But the most exciting exploration was when we actually looked at the genetic profile of this injury site in response to our nanoparticles, and we found that particular genes associated with neuroregeneration were actually now activated. And that was very exciting, because we feel that we could not only suppress neuroinflammation, but also promote neuroregeneration. So in conclusion, nanomedicine has a lot to offer to VCA, and hopefully I'm convincing you of that. There are areas that nanomedicine could be of great support to the future in patients: improved immunomonitoring and diagnosis non-invasively. We can avoid systemic side effects. We can personalize the treatment. As you know, no two VCA patients are the same. And we also are looking at how to best preserve precious organs and tissues that we need for our patients, and also prevent ischemia and reperfusion injury, which is very prominently present. So at the end, I thank you for your time and invitation. This is my lab, is the most recent snapshot of students, postdocs, and technicians, and a long list of collaborators we are very grateful for, and of course, incredibly grateful to the DoD for their generosity and multiple projects that have been recently funded. We have some projects funded by NIH, but mostly Air Force and congressional directed medical research programs. And thank you for your attention, and I'm happy to take any questions. All yours.
Dr. Elena, excellent presentation. I think we have to just, we'll take some time to gain all the knowledge that was contained in that short period of time. And I think we'll be in touch with you for that. I have a question with you regarding the local immunosuppression. How far are we from the human trials?
Oh, that's a very challenging question. I would say not too far, because we are currently testing this in monkeys. So it's hard to predict. It wouldn't be fair to my colleagues who are developing the technology, but I think maybe a couple of years, maybe less.
And I was also talking to Dr. Gorantland, and he was telling me about this Hemopure. Like we have been very lucky that Dr. Lenteri, who has already joined us in this session, so he has been very kind enough to deliver and to gift us 8 vials of Himerina, that Hemo2 Life. And then we have used it in one of our patients for oxygenation of the one of our donor limbs. And we could get very quick perfusion of the hand. But Dr. Gorantla was telling me that you are using Hemopure for, that's another substance for oxygenation of the tissues. I think it's already developed and clinically used, Hemopure. Are you aware?
That's would be best question for him. My lab doesn't work with Hemopure. We actually adopting our perfluorinated nanoparticles for organ preservation, and that technology is probably the youngest.
Okay. So that has not been experimentally tried in bigger animals till now, like what you are
We
developing.
we just got awarded to set that experimental paradigm in larger animals. We have some preliminary data in rats, but it's very much in a pilot stage at this point. However, we are trying to use expertise that's had experiences with this type of agents from clinical studies. So in essence, this technology has been applied in humans, just not in VCA. And we found that controlling the quality of the particles is essential for VCA. So we are at earlier stage of development there.
Well, thank you very much. Thanks a lot for your excellent talk. We learned a lot from it. And I would just ask the audience, is there any other question? I think there are no further questions right now. We'll take some time to grapple with the information and probably reach you with some questions
Please do.
Personally.
Thank you so much for having
Thank
me.
you very much for your time and contribution. Thank you.
Thanks.
Now, could we welcome Dr. Lanteri? Dr. Laurent, are you here?
You see me?
I can hear you, but I'm not seeing you right now. Yeah, I can see you now.
Okay.
Dr. Lanteri, you are extremely welcome, and we are thankful to you that you are joining, sparing your time in this meeting of Indian Society of Reconstructive Transplantation. I would introduce Dr. Lanteri. He's presently serving as head of the Department of Plastic Surgery at Paris University, Hospital Pompidou, and he has performed 8 face transplantations. I think he is the foremost authority in the field of face transplantation in the world, including 1 face and double hand and 2 double hand. And his basic focus other than this is the clinical research in organ decellularization and oxygen delivery. So I would welcome Dr. Lanteri, who is a pioneer in the field of reconstructive transplantation, to hear from his experience. Welcome, Dr. Lanteri.
Thank you very much. Thank you, Mohit. I wish I could be in Kochi, and I hope the world's going to open in a few months so we can travel again. I went to my first meeting in Netherlands outside France a couple of weeks ago. I went in England this week, and I hope we can travel back to India as soon as possible. I'd love to see Kochi. I've never been to Kochi, and to share and speak. And it's good to have Zoom, but Zoom is not the same thing than to be together and eat and speak together.
We want you here, actually, so we'll soon meet, I'm sure.
Okay. Okay, so I'd like to speak about face and hand transplant, but to fix it globally in our plastic surgery and what I have 2 disclosure. I'm consultant currently for Imarina, who is the drug company is delivering Hemo2Life, and another biotech who's doing with something different to working with breast implants. So if we look back at history, vascular surgery has led to transplantation and to replantation. You know that Joe Murray did the first kidney transplant, and he had a Nobel Prize. It's the only plastic surgeon who had the Nobel Prize. And microsurgery led by Harry Bunke led to a lot of work, finger replantation, but also replantation of big segments of facial elements, like here in this scalp replant, and leading also with the knowledge of anatomy to auto-transplantation. When I speak to my friends doing kidney transplantation or other transplant, I say I do more transplant than you because I do auto-transplantation. That's why I'm very interested in ischemia reperfusion injuries. Those can lead to facial reconstruction, like in this patient, to limb reconstruction. But sometimes when the elements are so much destroyed, you don't have spare parts elsewhere in the body to do the reconstruction, like in this explosion of both hands, like in this burn patient, or in these cases we see more and more often, which is with the ischemia related to septic shock, with these patients that are quite amputee. We have more and more of those patients that didn't survive 20 years ago, but now survive, and we have those patients. So with this patient, you only have composite allotransplantation to solve. If you have plastic invasive surgery and transplantation, two words that didn't speak together for many years, with microsurgery, with the progress of immunosuppression, if you are donor and recipient, there is a small place for composite allotransplantation. Of course, hand is the first one, and it was the first one realized in 1963. People do not remember that the first, except Sancone Sandemia, did it in the 4th century, and Tagliacozzi tried to do it in the late 16th century. But the first of the modern era was 1963, the first hand transplantation. That only lasts for 3 weeks in 1963. In the 80s, with the progress of the cyclosporin, there is different attempt of composite transplantation. And it's in 1998 that Jean-Michel Dubernay, who passed away this year, if you didn't notice, did the first hand transplantation in the modern era, using 3 drugs that haven't changed since the 20 years. Induction with thymoglobulin, tacrolimus, and MMF, and steroids. So here's one of my 2 hand transplant, which is Laura. Laura was a wonderful young woman, very willing to live. She was 19 years old, doing a hospitality school in Switzerland, very active, and unfortunately, she had a septic shock and had to be amputated. She had prosthesis, and the question, is better to have prosthesis or to have hand transplant, is that when you look at her, of course she could do things, and she wore her prosthesis for 9 years, but she was not smiling anymore. And that's what you could see. You're not restoring only function, you're restoring some dignity. She says that she didn't want to have excuse me, I put this down out. She didn't want to have other things than hand, because her prosthesis were functional, but it was plastic. It was not real. And when you see how she wears her hand, how she passes her hand in her hair, it is more and more functional. We performed this surgery in the US because of political problem in France at that time, with my friend Scott Levin, who is a leader in hand transplant and a very good friend. And what you could see is how much he needed to have physical therapy to restore her hand. And she's now pregnant. I think she's only a VCA patient that has been ever pregnant, so she's pregnant. And it's very good news. She's 32, pregnant, doing well. She's going to have a baby, and life is there. Basically, without hand transplant, she couldn't have it. In face transplant was brought to us by Peter Butler, who spoke about it in The Lancet. Never done any face transplant. Said we weren't going to do it. But what is face transplant? It's more complicated. Today, we can reconstruct different face defect by a combination of free flaps, like here, bone graft, skin graft, forehead flap, which was brought for us by the Indians. As I always say, India plastic surgery is one of the mother of modern plastic surgery. And these large defects like that can be repaired with this combination of different elements. These are 2 patients that were bitten by bonobos, treating bonobos in Africa, and the bonobos were poached by others and were aggressive, and they came back to France so we could restore the faces. So facial reconstruction is a combination of this. So why do we need face transplant? Because we have failures. If we have total destruction of the eyelids, of the total destruction of the lips, or more total destruction of the soft tissue of the face, there is no other solution than face transplant. We went through a very long process of approval to get it, many years of work. We had to set the surgical team. we had to work in the analytical lab. The first was anatomy. We had to go back to anatomy to describe how to do it. That's a key element. Before knowing the immunology, we went to the anatomy. We had to set the team, to organize the logistics, to do the transplant. And basically, there are two transplants in the face. The upper face, where you have the eyelids, and the lower face, where you have the lips. Combined together, you can do a full face. So these two elements, at first I could not manage the upper face, so I only did the lower face with the lips. And these are free flaps. These are technical details that have been in many articles to how to do it. But basically, these are free flaps, free vascular flaps that we are taking and that we are giving to the patient. This is Jérôme in 2010. He said he could not shave his sem. And this is the face transplant in 2010. You can see it's a mask, complete, and we take it to the biggest vessel possible. We take it all the way to the origin of the facial nerve. It's very important to have the biggest elements so you don't have any thrombosis, you don't have any problems, you have the most reliable and the most reproducible transplant. What I try to teach, and I came to India once and I did this section, is to have something very reproducible. The technique is reproducible. My fellows can reproduce the harvest. And you can see here the transplant to the external carotid, the biggest vessel possible so you don't have any problem with thrombosis and technical problems. Sorry, I wanted to finish. So you can see here now, this was in 2015, 5 years after a transplant, a complete different face. You can see anything. He was very happy. He could walk in the street. He was expressing that he had a normal life. Nobody was looking at him like he was a monster. And he worked as in a library. He's very intellectual. He wrote a book. He's writing a second book. And he feels better in his skin. What he says, he accepts himself. But this was physically a success, and he felt to be back in the humans. So here's the transplant. We did 7 patients, 8 transplants. I will speak about the another one. So here are the different elements with the long-term results. On the lower, you have 4 ballistic traumas, 2 neurofibromatosis, 1 burn that we'll speak a bit later. 1 was 2 were self-inflicted ballistic traumas, and 1 committed suicide, even if he had the best result. What we saw is that with hand and face transplant, the family support is very important. Patients are doing good if they have a very strong family support. We're discussing with Steve Ovius in Netherlands, the same thing with his team. Other patients are doing very good. This is Andres Rodriguez. He had a face transplant, and he has Facebook, face transplant Facebook. He looks himself, he's doing very well. He travels all the planet. He has almost no problem. Here's probably the most impressive, the first transplant. He's Pascal had neurofibromatosis. This was in 2006. He's today the patient that has the longest living with a face transplant. We are in 2021, almost 22. He had multiple operations by the best plastic surgeon in France, and he had this result. And here he is, same place in Paris, outside the store display before Christmas, 1 year after, and nobody's anymore looking at him. He could work. He had a job as an accountant. He has a normal social life. Not completely normal, of course, but normal. So we went from fantasy to reality with doing those transplants. Yesterday, with the what we see from the First World War, with what we call les gueules cassées, the broken faces, well, we couldn't do much more. We had improved with free flaps, but we have those ones. And this is the change of paradigm we have. And we still have wars, and we still have problems. This is a patient who is in waiting list right now. We have very few patients. And he's a burn patient, he's a military that fell on electric wire and it's completely burned. And the only thing we could do is a free flap, and he needed a face transplant. These are the indications you have. So should we go further? Should we go further? And we published in the Lancet our first cohort study. and asking ourselves, should we continue? The problem is of course, immunosuppression. At the beginning, we have immunosuppression, but with time, we have less immunosuppression. Anyhow, you have immunosuppression and all the problems you have in immunosuppression. First thing, you have acute rejection. All of the patient, 85% of the patient that have completed tissue have some form of acute rejection that are, I would say, are quite easily treated, but it still impact on the transplant. Do you have toxicity of the drugs? That is not a problem. But you have sometimes hyperacute rejection. This is a patient that had burn, bilateral hand and face burn, and all the body was burned. And we performed a double hand and face transplant. With initial success, the patient was doing very well. He went out of ICU. But a couple of weeks after, he started to have edema, some form of necrosis. At first, I thought it was septic because it was septic, but it was everywhere. So it was not logical to have septic. He unfortunately died from a cardiac arrest after many surgeries. And we discovered that he had high level of donor-specific antigens. And we went back to see his serums that we had previously, and we discovered that by doing more testing, more reliable testing, that he had initial donor-specific antigen we couldn't detect. And then we went to see burn patient. We had this patient on waiting list. We couldn't find any donor. He had very high positive reactive antibodies. And we look at the population of burn patient. Most of them are sensitized. Most of them are sensitized, meaning that we cannot have the same treatment. We need to have something to desensitize the patient before we can transplant. That's why we stopped doing burn, except the patient I just showed you, because it's just on the face, and we managed not to have any positive reactive antibodies. The other thing is chronic rejection. Here's Isabelle Dinoir, the first face transplant, another of my patient who died and had chronic rejection. One of my patients that I showed with a full face had pristinamycin, which was given by his GP, and had thrombotic microangiopathy, and it started to have a vicious circle we cannot control. And progressively, we have this chronic rejection that you have with the sclerosis on the face, more and more intense with necrosis. And we saw that he was raising his DSA progressively, beginning not a thing, and more intense. And we had this necrosis of all the face. We had then to remove the face completely with DSA high level, which happens in any acute chronic rejection. When you remove a kidney, you have this DSC, and it's more difficult to find out. We had to cover it temporarily with skin graft. Very difficult, very intense. Patient was in intensive care for a long time. And here's the transplant we did. The first, I didn't mention that when we harvest a face, we do a mask to the recipient so we can give back to the family. That's what I just showed. This is how we harvest the face, the dissection all the way, and this is the full face that we had to give. The dissection is very standard, is very reproducible. I've described it many times in books and in articles. Training it can be quite easily once you have the technique. And basically, we take all the face, all the elements, all the way down to the most biggest vessels, so we can hook to the big vessels to the face. And you can see here, I will wash it. The replant. Here we use the Hemotolife as Moritz said. We had the authorization to use it, even if it was not. It was something what not give. We had special authorization to use it. And what happened is that the same thing that he observed is that we had, like if there's no ischemia, just pink immediately. And you can see just after the transplant, thumbs ups. All my face transplant do thumbs up. They have tracheotomy, they cannot say thanks, but they do thumbs ups, which just thing. Here's the technique. We harvest all the way deep to the biggest vessels, to the trunk of the nerve. We do superficial parotidectomy on the recipient so we can put back all the elements and hook it to the origin. I know that my American friends do not do that. They try to do more distally, saying there would be syncynesia if you do it proximally. I never had any syncynesia. I think there is a brain adaptation making there is no syncynesia whatsoever. It's just the motor nerve and the fibers go where they need and the brain interprets. the biggest vessels. The difference for this case is that I went all the way deep to the internal jugular, so I have the biggest elements to have enterocide and have no problem with the vessels. And here's after. The follow-up was difficult. We had to treat these donor-specific antibody. It was a positive cross-match. I had to do a positive cross-match. I had a patient, I have a ABO compatible, a young patient, one donor, and I think I had one chance to pair. So we did, I accepted the positive cross-match. We disclosed the patient 3 months after. I went to the press, CNN and everything. Patient with my good friends but it was difficult. It was very, very, very long. He stayed in hospitals for 1 year since we admitted and removed the face. We did the transplant. It was out. And progressively, we look at these DSA. The DSA from the first transplant went down very, very quickly. The DSA from his second transplant were very high and are progressively going down. And the patient now is more than 3 years post-op, is doing well. So no anything, the kidney is doing well, everything is fine, and is back to life. You can see here is what for a French tabloid, Paris Match, with 2 of my hand transplant, 2 face transplant, discussing together. Very intense for me also to see those patients part of my history, besides their history. And how can we improve the outcomes in transplantation? Harvest, planification, rehearsal. That's the key point. Planification in hands. We do 3D imaging. We do cutting guides. Every elements. We even studied if we could do partial hands. Different elements are very important. Checklist. We do checklist because there are so many people coming to the OR, so many elements that when we do the rehearsal doing to cadaveric dissection, there's a checklist. You cannot do a transplant if you don't do all those checklists. Everyone has a checklist. We hang to the board, and someone has to read the checklist, what we're doing. The transport, very important. Ischemia perfusion is a key element for rejection. We can use perfusion machine. We've been studying perfusion machine in Kurt Cetrullo's lab in the US. It's something interesting. You have the perfusion machine that are used clinically in liver and kidney transplant, but what I think is more efficient is what I've been using is this Hemo2Life. Hemo2Life is extracellular hemoglobin from seaworm. Seaworm gets its oxygen on high tide and lives on its oxygen on low tide for at least 6 hours. He has extracellular hemoglobin, hasn't have any red cells, and these hemoglobins keeps 40 more times oxygen than our hemoglobin. And the interesting thing is that it doesn't have the vasoconstriction effects of our hemoglobin. If you put our hemoglobin in our vessels directly, you have vasoconstriction and you have kidney destruction. It's not the case here. The other interesting thing is that it is not, it doesn't give any immunoreaction, which is strange for a protein. Well, it's because it's the shape of hemoglobin is universal on any animals and every plants. The shape here, and there is no immunoreaction to this molecule. So it's been used in kidney. That's why we had the authorization. And in kidney, what we showed is that delayed graft function, which is normally 25%, meaning that you need to have some dialysis and the kidney doesn't work, is standard, was brought down to 7% on the patient that received the drugs. And more interesting, 4 years post-op, we just had this data. 4 years post-op, the survival rate of the patients, not the kidney, the patients, normally the survival rate of a kidney transplant is 85%, a bit better in Europe than in the US for I don't know which reason. And here in our series that had them at least 98%. So that's the elements. So we have now full authorization to use it in composite tissue, and this drug is going to be full authorized, I believe, in the next 6 months to be used in kidney transplant and most probably through every transplant. So for the transplant, what can we do for the transplant? You have the harvest, you have the transport, and the transplant. Of course, we can do immunomodulation. I just saw the very, very brilliant talk by Dr. Janjic and all these elements of the drugs. I've been into it for 25 years, looking, and I thought when I started that we could find solution to that immunotolerance. The problem that you can do it in animals, that these animals are not humans, and their immune system is very different. You can have tolerance in rats and rodents, but in big animals, it's quite impossible. We've been trying to do it. We've been trying that in primates. In primates, we had PTLD. We've been trying to do it in the swines. Well, if you have only one mismatch, it works, but if you have more, it doesn't work. Even if we're still trying to do it, it's quite complicated. So I said to my team, let's go to another field. It's too complicated for my surgical brain. I want to see more simple, more direct, do it the deceleration operation. This is something invented by Harold Ott. Remove the cells, have the scaffold, and we put cells. We all imagine that we are an amount of cells. It's not true. We are a scaffold with cells living in it. If we remove the cells of the recipient and we put the recipient of the donor and we put the cells of the recipient, then there is no immunosuppression needed anymore. It's done in small animals. Big animals are much more difficult. So we've been using that, of course, tried in animals with these elements, and we've been doing it on faces. And this is the work we're doing in Kurt Setula's lab in Boston. And here's a full decellularized face. There is no cell in it. You have a face, everything is there, no cells. So it's not immunosuppressive. It's not. There's no immunorejection if you put it. Of course, we need to put cells. You can put on the nose. You see on that with the elements. We're trying to put back cells. Then we went back to the animal model, trying to. We don't need to do faces. We just prove that we could decellularize faces. Now we have to have models so we can recellularize. Once you decellularize, so we have these elements of a fasciocutaneous flap. We decellularize it. It's fully decellularized. You can see that it's very, and you can see that the vasculature inside is, the elements are there, but there is no endothelial cells. If you hook it back, it thromboses immediately. You can do vascular staining, well, very nice pictures, but that doesn't work. The question is that once you put back these elements, can we recellularize the lytic fat? And we start with only one thing, just try with endothelial cell. We had different sows, and we just achieved this just with new testing. We have this endothelial cells. On the left, you can see the picture with endothelial cell in the vessels. And here you can see a flap. This is a decellularized flap with endothelial cells, and there's no thrombosis. It looks like it's living, and that's elements that we're going to put back in bodies. That's the next step, and try to put cells in it. These elements would be the first step. Then we could put cells into it. If you have the vessels, then you can make it living. And probably, if we can succeed it, we will not need any more these. So my dream is to have in the shelf right here all faces and hands that are decellularized that I could bring here and put cells into it and put that to the patient. Thank you very much.
Thank you very much, Dr. Lenteri, for the amazing talk. May I ask you a few questions?
Of course.
Yeah. My first question is, like you were saying in burns patients, you have stopped doing transplantation because of the problem of sensitization. So, like, do you have any specific regime which you have tried for desensitization? Like,
yes. So there are, first, we are now working with the burn units so that they will not use skin allograft if they think there is a possibility that you will need to have transplant, because that sensitizes the patient. That's the first point. First, try not to sensitize the patient. If they have blood transfusion, dileukocyte. So all these elements that will not give sensitization. Once you have a sensitized patient, it's like a kidney when you do kidney transplant on sensitized patient, we have protocol desensitization. If you read the paper on the Lancet of our retransplantation, we describe all the desensitization that we used, rituximab, apheresis, different elements that we've been using to desensitize. It's not different from desensitization in kidney transplant. We need to be desensitized on sensitized patient. The one that are more expertise are the heart transplant, because they have a lot of patients that sensitize and it's much more difficult. They need to have strong desensitization before they put a new heart.
Okay, thank you. Another question, like the last part you showed the decellularized flap, and then you were saying that the vessels in that flap, you have been able to seed endothelial cells, like there is a first decellularized flap with the seeded vessels. How did you actually you were able to do the seeding of the cells in the vessels, like any specific
yeah, we are just preparing the paper that we will be publishing at least soon to see the relevance. It has to be technically we work. You cannot freeze it directly. You need to have a perfusion machine.
Okay.
And you need to have the low flow, cell by cell, something very low to have a progressive infusion of the cells. If you try to push too much, you have it stucks and you have intimal imperpetuum. Okay. So you need these cells. So we are writing the paper now for the first, I would say, success, because of the first step we have been raising. We have to, everybody can decellularize today, but the next step is to recellularize. And I think the next step is not to try to promote more cell ex vivo. Once we have the vessels, put it back in the animal and use it as the elements and put the cells while it's already in the animal, then they have the normal flow into it.
Okay. That's great. Is there any other question for Dr. Lantieri from the audience? I think that has been one of the most wonderful talks, and I really thank you for your great informative talk. I also thank you for giving us the Hemo2Life samples along with Frank Zal. And we have already used, one got broken and one we have used. We have 6 more samples, and I'm sure we are going to use it for the patient originally that it has been intended for our shoulder transplant. So we'll be updating you with that outcome as well. So once again, thank you very much for helping us and contributing for this meeting, and we would soon like to see you in India. So thank you very much, Dr. Lantieri. Thank you. Thanks.
Thank you, Mohit. It's a good session. Thank you so much.
Thank you, Selva. No. So, if anything else is there to discuss, Selva, otherwise we will conclude this session.
Yeah.
When are we meeting physically, sir?
Sorry, Selva?
It's Gopi here, sir.
Yeah, Gopi.
When are we all meeting and celebrating physically, not in the virtual thing?
I think you just post a transplant and call us.
We'll do so.
Or host some meeting in some military hospital in Kargil or Dras.
Tatastu will be done, sir.
Thank you. Thank you, Colonel Gopi.
Sir, wonderful session.
You want to talk, sir? Just
we can is there any other thing which we need to talk before we wind up the meeting, in fact? Because we had that session, I don't think we need to go further on that.
Yeah, as you said, we will just form a short group for all registered hospitals. We'll have a group, and we'll be sharing all the information within us. and we can start moving that. I think that is meeting at least one step we can take forward. Everyone will be aware of the cases, them with their blood group and other things, so that in case any help, definitely we'll be calling you, so that you will also be aware of the.
Yeah. I think we can have a, I mean, among the multitudes of WhatsApp groups, we can have a national hand transplant WhatsApp group.
Hardly around 10 hospitals are there.
Yeah, so we can have it, and so anything important can just come in that.
Yeah.
You can start. One of you can start with all the people as admin. We need not too much discuss anything further than anything like this can be put across.
Yes, sir. Definitely, sir. Right, sir.
Yeah.
We'll start it.
Okay.
Thank you, sir. Bye, sir. Thank you so much.
Right. Okay.
Thank you, sir.
Yeah. Thank you all very much for being here.
Thank you. Wonderful session, sir. Thank you for the great lecture.
Okay. Thank you.